I'll be shorter. They probably put me until 6:10, but we'll try to make it shorter, cover the most important topics, and try to keep you guys engaged. All right, so I selected a few cases to discuss. There may be some overlap, and maybe not, but I think we'll try to cover some of the important topics that we may encounter post-transplantation. Let's start with a 66-year-old male who was admitted 6 weeks after uncomplicated deceased donor kidney transplant with an increase in creatinine. He feels quite well, but he noticed a sudden reduction in urine output. So urine output is one thing that we definitely kind of reinforce patients to keep an eye on this, in particular early after transplant, as being one of the big kind of red flags for them to come in. He was on mycophenolate, prednisone, and tacro, prophylaxis, valganciclovir, and Bactrim, and was also on a ranitidine GI protection. 2 days prior to admission, his creatinine was 1.5, and tacrolimus trough level was 9.4. Today, his creatinine is up from 1.5 to 2.6. He had multiple anti-HLA antibodies, but no donor-specific antibodies at time of transplant. The pre-transplant T and B cell cross-match was negative. He received thymoglobulin for induction, and the allograft functioned immediately. He had a prior history of IgA nephropathy as a cause of kidney disease and had one prior transplant, who lost the allograft due to refractory rejection. He had benign prostate hyperplasia and hypertension. He was slightly hypertensive and on exam with a mild tenderness over the allograft, no swelling, and no other findings. So what is initial management should include, except measure a tacrolimus trough level, do a BK viral load, do an ultrasound, start empirical high-dose steroids, repeat a cross-match against the donor T and B cells. All right, so it's kind of spread out. So we're looking for the except. So what are the all reasonable initial steps except? So the right answer, or the answer that we would like you guys to choose, was empirical treatment of high-dose steroids. So remember, tacrolimus level is something you should definitely be checking, even if a few days earlier it was normal. BK viral load is also crucial, in particular during that first year period. Sometimes you can have kidney BK nephropathy without any fever or chills. Frequently you do that. Ultrasound is crucial because early after transplant you're thinking about structural changes, either a collection compressing of the kidney, vascular thrombosis, and so forth. And because this patient was highly sensitized, even the patient didn't have any specific, donor-specific antibodies, when you do a transplant, you're putting the new antigen there, so your antibody response may appear after transplant. So these are all important tests that you should be doing when this patient kind of comes in. So his initial results came back as tacrolimus at trough level 9.5, white blood count of 4.5, creative 30, platelets 160,000. His urinalysis was negative. He had an urgent ultrasound that showed mild hydronephrosis and no perinephric collections, and his cross-match studies are pending. So now, what is the most appropriate next step in management? You check a CMV viral load, you convert the patient to sirolimus, you reduce the tacrolimus dose, you do a renal mag-3 scan with diuretics, or you do an allograft biopsy. All right. Most of you chose to do an allograft biopsy, and that's correct. So the FK is not explaining the elevation in creatinine. CMV infection is very uncommon in the first 6 months after transplant. Remember, our patients are taking prophylaxis. and usually it would present with symptoms such as fever, diarrhea, or leukopenia. Mild hydronephrosis is actually very common after transplantation. And the reason is, remember that we are reanastomosing that ureter to the bladder and creating like a artificial valve by suturing the bladder muscle over the ureter. So you have some reflux. So mild hydronephrosis is not necessarily, of concern. For sure, in this case, we at least excluded a severe hydronephrosis that could explain the rise in creatinine, and there was good perfusion of the kidney. So I think this is, important to do, but it would not explain, and I think we want to still exclude a biopsy. So when you do a biopsy, there are a few complications that we worry about. The most common one is bleeding. And in particular, there's a bleeding that leads to what we call page kidney. So this is when bleeding happens under the capsule and then starts pressing on the kidney. So that's the one that we're most worried about. The second thing that it can definitely happen as well is if you create an AV fistula after the kidney biopsy. This is a concern because it also kind of affects the function of the kidney, and sometimes it may need occlusion. So those, the bleeding complications and the AV fistula creation after a biopsy, not creation, as a consequence of the biopsy, are two major complications. So this is the biopsy. This is a PAS stain, and this is a C4D staining here on the right side. Okay, so which of the following is true? The most likely diagnosis is acute antibody-mediated rejection. The most likely diagnosis is acute polyoma virus infection. Plasmapheresis may be useful, but is contraindicated because of the bleeding risk early after transplant. The most likely diagnosis is acute cellular rejection. Administration of thymoglobulin is indicated. I'll give you 20 seconds. And most of you chose the right answer, which is acute antibody-mediated rejection. So why do we choose that? So there are two features that are very particular about it. One is in between the tubules, you see those capillaries that are distended and full of cells. That's peritubular capillaritis. We don't see a lot of T cells invading the tubule, which is classic for the cellular rejection. And two, we have the C4D deposition on the immune fluorescence, which is classic for complement activation in endothelium triggered by the antibody. So there's no evidence of polyomaviruses that causes this nuclei to be very enlarged and also causes tubulitis. Plasmapheresis and IVIG will be the initial treatment of choice for these cases, and thymoglobulin is not effective against antibody-mediated rejection. If you have a strong cellular rejection component, you can consider the thymoglobulin, but thymoglobulin, if you recall, is a T-cell depleting agent, and here we're dealing mostly with an antibody process. So the patient had a repeat anti-HLA testing done, and suddenly now we look at all the anti-HLA antibodies that he has, and we look at the donor HLA antigens. And then we try to match and see which one of those recipient anti-HLA antibodies may recognize the donor. And so this is just some kind of a manual way of just kind of going over and say, okay, so DR17, do we have DR17 on the donor? I said yes. And then you screen all those class 1A, B as well. And he has no class 1. So it's a class 2 antibody against DR17 that's causing this. So antibody-mediated rejection have increasing frequency in the past few years, in part because we're diagnosing better with some of the assays available for anti-HLA testing, and also because we're transplanting higher risk patients that have lost their prior grafts and are being transplanted a second, a third, and a fourth time. So we always need that triad of donor-specific antibody in the circulation, the presence of these peritubular capillaritis, as well as glomerulitis. Those are the two crucial endothelial activation markers that we see in antibody-mediated rejection. And you can have in about 40 to 50% of patients the C4D staining. C4D is not a requirement, but when it's present, it kind of also reinforces the diagnosis. So you've seen some of this, but antibody-mediated rejection can lead to injury based on two major factors. So one is complement activation. So that goes and causes the endothelial injury and form pores on that endothelium that ended up causing endothelial death. And you can also have activation by innate immune cells that would then secrete cytokines and other factors that cause injury to the endothelium. So this is what we call cytotoxicity mediated injury. So both this and the complement are the causes, the majority that would cause the injury to that endothelium layer. And sometimes the antibody, even without those, can cause direct injury. But this is the mechanism to which it happens. From antibody-mediated rejection, on this case, we'll move into living donation risks. So here I have a 30-year-old female who is interested in donating a kidney to her 68-year-old father, but is a concern about the risks of her health, okay? She has successfully passed all her pre-donation tests. So which of the following are true arguments about kidney donation? The risk of peri-op death is 3 in 10,000. The risk of end-stage renal disease over 40 years is twice that of the general population. The risk of peri-op complications is higher with open compared to laparoscopic nephrectomy. There's no higher risk of preeclampsia post-donation, and carrying one APOL1 risk allele increases the risk of renal failure after donation. I'll give you 20 seconds. All right, so it's a little bit spread out here in terms of what is true. Most of you, 45%, chose the true one is A. Risk of peri-op death is 3 in 10,000, and this is true. So this is the number you should have. What about the risk of end-stage renal disease over 40 years? It's actually 8 times higher after kidney donation. It's a very, very small risk, but it's 8 times higher compared to the general population. Usually the peri-op complications are similar between both laparoscopic and open laparoscopic nephrectomy. There is a higher risk of preeclampsia in women who donate and then later have pregnancy. And from what we know, one APOL1 high risk allele is not enough to cause kidney failure after donation. You require the 2 and some additional second hit that we don't understand yet so well. So what are the numbers that I use when I talk to patients about their risk of end-stage renal disease? So this is probably one of the best studies. So it's a JAMA paper that compare the living donor risk of end-stage renal disease in different races. And as you can see, over time, the risk of end-stage renal disease increases. It's highest among black donors and lowest among the white donors. But it's about 1 in 133 and about 1 in 440 white donors may develop end-stage renal disease. So these are some of the numbers that you may quote, and this is a small risk if you think about the population basis, but for sure I think it's important for the patient to know where they're coming, where they're getting into it. We had a really kind of a broad discussion in the community about if we should be doing APOL1 testing on the donors prior to donation. And there's still a lot of controversy into that, just because 15% of the African American population have the 2 high-risk alleles, but not all of them will develop kidney disease. So if we start limiting transplants from all these patients, there may be an issue of selectively preventing recipients that are African Americans from getting potential donors. So what we in this paper, and you guys can read it with their own leisure, we kind of go over the arguments of who are the patients that we should be testing. And I think in general we believe that younger African American patients that are being considered for donation, they should be tested for APOL1 testing. It wouldn't be a no, in case they have the 2 high-risk alleles, but it would be something that would be an additional risk factor that it has to be taken into account, like having high blood pressure, like being slightly overweight. So those are all risk factors that are important. The second aspect of why age is so important and why younger donors may be tested is if you look at the risk of end-stage renal disease, it's much, if you get two exact same patients and you look over time, their risks, if you're transplanting or donating, removing a kidney from a young donor, their risk is 1 to 50 of developing end-stage renal disease. If the patient is already 60 years old, then he hasn't had any problems with the kidneys, the risk of developing end-stage renal disease is 1 in 150. Okay, this is because we cannot predict everything that may happen from the 20-year-old until they're like 60. So there's a lot of unforeseen consequences of donation and other things that may occur that may affect that. So with the older donors, we may take that risk, but with younger donors, I think we have to be very careful. All right, third case, changing mental status after transplant. So this is a 68-year-old woman who had a history of recurrent urinary tract infections and kidney stones, who underwent a deceased donor transplant 5 days before. She was on triple immune suppression, Bactrim and amlodipine. She had a slow graft function, but urine output was above 2 liters and creatinine down to 3.5 from 4. So she presents with sudden onset of changing mental status when we started rounding in the morning in the hospital, and her vital signs were stable. So what is the most likely cause of this sudden change in mental status? A stroke? Uremia? Her creatinine was 4, was about 3.5, still high. Hyperammonemia, sepsis, or meningitis. So we're talking someone 5 days after transplant that has a sudden deterioration of mental status. And you guys can vote. All right. So most of you suspected sepsis. I think sepsis is always something, that you have to keep in the back burner because, you just gave a lot of immune suppression to these patients. They are on prophylactic antibiotics. They take Bactrim, but it could still be something, resistant to that. But the diagnosis that you don't want to miss is hyperammonemia, okay? So this is a case of non-cirrhotic hyperammonemia, which can occur in patients who have been colonized with urease-producing organisms, such as ureaplasma, mycoplasma, or proteols, which cleave the urea into ammonia. And why is this so important? Because, the mortality, if you look 5 years back, was 100%. Now it's a little bit lower. And the reason is that if you don't diagnose quickly, the hyperammonemia will cause brain edema, and these patients then have actually a very quick death. So in our case, we were rounding in the morning, and we have seen another case of that a couple of years back. And what was interesting is that this patient had an odor that looked like, smelled like urea. And, we see, it was ammonia in the end when we found out, but that urea, smell that sometimes you see in patients that come in. And she had that in the morning. And the first thing we did was to check an ammonia level. And her ammonia level came back at 450, okay? So this is extremely high. And, the best treatment or the only treatment that we have in the short term to get that ammonia down is dialysis. So this patient, within like an hour, had been started on dialysis, and you can see that we can nicely get the ammonia down. Her mental status did not improve. During dialysis, she actually had to be intubated because of the change in mental status. And then we had some of the genetics people that came in. They're very used to some of these, ammonia metabolic disturbances, and they started her on all these agents here on the middle, which try to prevent or shut the cycle of ammonia conversion. However, in this case, we also started levofloxacin from the beginning, in order to try to get rid of that infection. And then later on, he was converted to doxy and then Cipro. And there was some some protein intake that had to be kind of controlled on that. So this paper actually was just published, but we are able over time by continued dialysis to get the ammonia down. And then with the antibiotics, by getting rid of these urease producing bacteria, the ammonia production resolved. And the patient, after about 5 to 7 days, started to wake up again. So there's a big delay in terms of when you start to reduce the ammonia and when the mental status improve. And we got a couple of head CTs, and she didn't have the brain edema that we have seen in a prior case. And so it was a matter of just the timing. So if you delay this diagnosis a day or even 2, this patient will be dead. So this is something that, you definitely have to think about. Immune suppressed patients that have a sudden changing mental status that you cannot explain. I think the sepsis, again, is something definitely you should keep high on your list. I think that was a great call, those that selected that. But if you have no other evidence, I think you have to think about sending an ammonia level. Case. So when you give the immune suppression, so great question. We don't know exactly, but depending on the amount of immune suppression that you get, and if a patient has been previously colonized, it can sometimes basically release and have an expansion of these bacteria. We don't know also if the antibiotics that we're giving was causing some selectivity into those bacteria. What was very interesting in her case is that we went back pre-transplant, about a month before, and she had a urinalysis that had a pH of 9. Okay, a lot of these urease producing bacteria, they produce a very high pH. And she also had a kidney stone on one of her kidneys that was not a classic staghorn, but it was definitely like a pelvic kind of stone. So she was clearly kind of colonized by this bacteria. And the prior case reports that have been done on this were mostly from the lung transplant population of patients that have been colonized by this bacteria. And then once they get the immune suppression and they get the traditional regimen, this bacteria kind of reappears. So I think the colonization and the addition of the immune suppression was something that kind of triggered that, after transplant. And by just treating with the antibiotics, that kind of resolved. But it's, again, those cases that it's hard to predict. Now, if I see again a patient who has a urine pH of 9, I probably will put this patient on some prophylactic antibiotics just after transplant that covers some of these bacteria, such as levofloxacin or doxy. So this is some of the learning points I think you may have going forward. Case 4. Fever, malaise, and nausea 8 months after transplant. So this is a 54-year-old with history of IgA. He had a deceased donor about 8 months prior. Now his 5 days of fever, fatigue, and nausea. He got a 4 out of 6 HLA mismatch. He was donor CMV positive, recipient negative. Had a recent contact with a patient that was PPD positive, who is on INH. No travel or other symptoms. He is on mycophenolate and tacrolimus. He has a fever 102, creatinine stable, TACR is 11, white blood count is 3.5, hemoglobin 12, and a little bit of elevation of AST and ALT. Chest X-ray is pretty unremarkable, maybe some increased markings. And all appropriate initial next steps, except should you induce a sputum for pneumocystis and TB, get blood cultures, get a CMV viral load, get urine cultures, get a renal ultrasound. I'll give you 15 seconds. All right. All of you, most of you, 60% got the right answer. So I think the ultrasound is the only test that, you should probably, there's no reason to get it early because, he doesn't have any kidney dysfunction and you're thinking more about the infection side. So you want to start with the urine culture, CMV viral load, blood cultures, and sputum. We're particularly concerned about, being donor negative and recipient, donor positive, recipient negative as being one of the major issues. So when should you order a renal transplant ultrasound? For clear, if you have a rising creatinine after transplant, this is one of the first tests you should order. You should also think about ordering any patient post-transplant that has a urinary tract infection, because you want to make sure you don't have an obstruction, an abscess or stone or something obstructing. And if anybody who has a allograft tenderness should also get an ultrasound. So we've been using ultrasound now in the clinic as well as in the hospital. We have our own kind of portable ultrasounds. And it has been, kind of eye-opening the number of times we have been able to identify things early and provide really kind of timely interventions. And this was one of the cases that we saw this patient and had, a moderate to severe hydronephrosis, and a prior ultrasound was completely normal. So renal ultrasounds can be very useful, in particular in transplant cases. And in transplant, it's very easy because the kidney is very superficial, so you get really good quality images, and you can quickly exclude hydronephrosis. You can quickly exclude changes in perfusion or any presence of collection around the kidney. So tests that were done here, blood CMV PCR was highly positive, induced sputum was negative, and he was discharged on valganciclovir 900 milligrams twice a day, and mycophenolate was held. So this is a common approach when we have CMV, try to reduce the immune suppression, in particular mycophenolate, and put the patient on valganciclovir. 1 week later, his afebrile exam was normal, had some labs, but now the white blood count was 1.2. All other numbers were stable. So which of the following is the most likely etiology of this patient's leukopenia? Acute bacterial co-infection, valganciclovir resistant CMV infection, marrow-suppressive effect of valganciclovir, marrow-suppressive effect of tacrolimus, or CMV-associated splenomegaly. All right, so most of you got it right. Marrow-suppressive effect of valganciclovir. So this is one of the major issues that we have after transplantation, because this leukopenia, doesn't mean that, these white blood cells are not functional, but we have to reduce the immune suppression. So, how do you sustain this? How do you keep this patient on valganciclovir to treat the CMV, but at the same time, make sure this patient is not at high risk of developing infection? And, any case like this, the first thing you want to do is to give GCSF to try to boost up the neutrophil count and prevent them from developing infections. CMV resistance is very uncommon, so it's less than 10% of cases and not that early. And the patient had, less fever and other things that suggest that the valganciclovir was working. There's no other evidence of infection, so I think, that's not a major concern. But bacterial co-infections can sometimes cause leukopenia. And tacrolimus in particular is not associated with leukopenia. Mycophenolate is the main agent that may affect bone marrow production, and CMV is not related to splenomegaly. So this is also a very common complication that we can see in up to 1 in every 2 patients that get a kidney transplant. It can happen at a peak at about 100 days after transplant and may last 1 to 4 weeks. So this low white blood count is multifactorial. It has to do with the induction therapy that was used. It has to do with some of the maintenance medications that are used, and also, some of the other agents that they are using combination. So bacteria and viral infections are important to exclude, because they can also lower the white blood count, as opposite to the increasing white blood count that you may see in the general population. And the main complication or concern about those neutropenias is the frequency of infections that may occur. So we do a selective approach in general of treating neutropenia, not in this particular case because we already had mycophenolate stop when he developed CMV infection. But usually we start by reducing the mycophenolate and sometimes stopping some of the prophylactic agents, okay? And then, for example, for CMV, if they are on valganciclovir for prophylaxis, you may change, instead of doing the prophylactic therapy, you just do monitoring of the CMV viral load to protect this patient from developing this leukopenia. If it's persistent, you may then use GCSF, and there's no clear risk of rejection giving GCSF, but for sure the low white blood counts and the immunosuppressant reduction may increase the risk of rejection. All right, from CMV, we'll move into, only one extra thing about CMV, and you guys probably saw this with Sarah Heyman. So there are two new agents that can be used for CMV treatment: letermovir and maribavir. So these agents, initially have been used mostly for resistant cases of CMV infection. It seems maribavir is a better agent, and one of the advantages of some of these agents, in particular letermovir, is that it doesn't cause low white blood count. Okay, so in the future, depending on how good these drugs come out on the trials, maybe it's going to be a better drug for us to use in transplantation, because we don't want to, we want to still have the same amount of immune suppression, and even though the valganciclovir lowers the white blood count, it's not causing really immune suppression. It's just keeping the numbers of cells down, so it doesn't affect the function. So that's some of the function versus number issue that we face that's important to keep in mind. Case 5, transplant candidacy. So we have an 82-year-old male who comes for a kidney transplant evaluation. I kid you not, there's a lot of 80-year-old coming in now to get to be donors. And then the question, well, this is actually the recipient, but the donors is true as well. And this is a biopsy-proven diabetic nephropathy who has a history of basal cell and squamous cell cancers, all removed surgically without any invasive futures. And this patient in particular has never been exposed to EBV or CMV, and he has no anti-A antibodies. His blood group is O. So all statements about his risks are true, except, so IgG EBV negative status increases risk of PTLD. Post-transplant skin cancer will increase over time. Having no anti-HLA antibodies will make it easier to match a kidney to him. He faces a longer wait for a deceased donor kidney than someone with blood group A or AB. His age over 80 is a contraindication to transplantation. So answer E is the wrong one. So, we are taking now patients that are above the age of 80 and giving them a kidney. The benefit, starts getting smaller and smaller once they pass their 65-year-old, 70-year-old, and so forth. And then if you look at survival in some of these 75 and 80-year-old, the survival, it's not significantly increased as you've seen with somebody that's much younger. But then the issue becomes a lot of times the quality of life, right? So you put somebody on dialysis, and we know that mortality in dialysis is extremely high. But when we're talking about somebody already in their 80s, how many years extra do you expect of this patient to have compared if they would just stay on dialysis? And the benefit of that number-wise doesn't become as significant, but there's the issue of quality of life. And there's also the caveat that, putting an 80-year-old through surgery may cause a short-term higher risk of mortality just because of the surgery and some of the potential complications. But in any case, I think a majority of programs now do not have an age cutoff. It all depends on their kind of real age, not only chronological age. And if you look at cancer, we do see that, as you get older, your risk of cancer increases, and in there for sure the additive risk of immune suppression. And it's interesting that once your immune suppression, is lower, or say if you stop taking your immune suppression and go back on dialysis, that increased risk of cancer, suddenly kind of go back to the general population. So in part because of that effect on viral infections as well as immune surveillance. Immune suppression toxicity. So let's talk about this 32-year-old female who received a 6 HLA mismatch from a living donor, and her PRA was 50%, and now she has tremor and perioral numbness when her TAC level trough is around 10. These symptoms have improved with a current level of 7, but they're not gone. And, she's CMV IgG negative, positive, and EBV negative. She takes 3 twice a day of attack, mycophenolate and prednisone, and she asks about other therapies that are available to her. She has a GFR of 38 and no proteinuria, creatinine is 2, and the K is 5.4. And this is a major challenge we face with patients after transplant, that sometimes they have very specific side effects that affect the quality of life, and they get very fixated into that, and they want to change it. And so the question is, what's the best next step in management for this patient? Should you convert it to sirolimus, one of the mTOR inhibitors? Should you convert this patient to belatacept? Should you convert this patient to once a day TAC? Should you reduce the dose of trough level to 4 or 5? Or should you just stop the tacrolimus and increase the mycophenolate dose? I'll give you 20 seconds. Conversion to once a day TAC was the answer that most of you selected. And I think this is true. I think it's definitely worth trying this patient on once a dose. So the mTOR inhibitor sirolimus is contraindicated in this case. She has a GFR that's kind of on the lowish side. Belatacept is a great potential alternative, but this patient is EBV negative. So that's a major contraindication to use belatacept. And some patients with this extended release, they do report less side effects, and in particular because you have less of a peak of the drug. So it's worth a try in this case. I think she has a 6 HLA mismatched kidney, so I wouldn't reduce the trough level of this patient in terms of the current TACR level, because that would may put her at higher risk of rejection. And also withdrawing the CNI completely, as I told you before, this is a really high risk approach to do, and we do not recommend routinely. So this is one of the curves that shows the differences between the immediate release and the slow release. So the difference has to do with this peak and how the slow release, it's a much smoother kind of absorption overall. So the AUC below the curve, the area under the curve is exactly the same between both drugs, but you don't have that peak early on. And we do see some patients that when they take the pill, within an hour, they start having a lot of tremor and sometimes headaches. So this is where the potential benefit of these once-a-day drugs comes in. There's some issues of, if patients have GI disturbances and other things, that sometimes the absorption is not great. So there are issues as well with some of these once a day, but I think it's definitely something to be worried about. We also saw some side effects of the CNI on this patient that it's very particular. I think the one is hyperkalemia, and we see this often. Patients sometimes are on Bactrim and CNI, and this can also lead to this issue. There's usually a reduction in renin that's triggered by the calcineurin inhibitors, and that's one of the most common causes of the hyperkalemia. And then the tremor, in particular in tacrolimus, this neurotoxicity, it's something that's always a concern, and we always try to ask patients about it. All right, fever and abdominal pain now 2 weeks after transplant. So this is a 45-year-old with diabetes who got his first deceased donor transplant about 2 weeks ago. She now has a fever of 100 degrees and lower abdominal pain. There's no dysuria or frequency. The meds, she's on triple immune suppression, Bactrim and valganciclovir, no other meds. Vital signs are fine. Blood pressure a little bit on the lower side. There's a JP drain lateral to the wound, which is draining about 150 cc's every day. And the graft, it's mildly tender. The wound is healing well. Her creatinine is 1.7. White blood count is up 18.5 from 7. And she has about 20 white blood cells in the urine, 1 plus blood and 1 plus protein. So fever and abdominal pain 2 weeks after transplant. So all are appropriate next steps, except ordering a urine culture, do 1 dose of steroid pulse, order a blood culture, order creatinine on JP fluid drain, order an ultrasound of the allograft. All right, so most of you got the right answer. So we don't we usually avoid as much as possible any empirical treatment with steroids. If you're concerned about rejection, you got a biopsy. In this case, we're more concerned about infection than anything else. But sometimes, a rejection, particularly in patients with lower immune suppression, can present with fever and tenderness over the allograft. So when we think about infection, this is something probably Sarah has spent a lot of time on. You got to think about when the infection is happening post-transplant. And this has also to do if the patient had any recent rejections or anything that would kind of reset the clock. So within 1 month after transplant, there are post-op infections, there are donor-derived infections that are important. Between 2 and 6, there are a lot of opportunistic infections such as BK, some GI parasites or endemic infections. And after 6 months, a lot of the more community-acquired infections such as pneumonia, UTI appear as most common, as well as CMV, because you're stopping the prophylaxis at 6 months. So the issue of CMV becomes a concern. So in this case, urine and blood cultures were ordered. JP fluid creatinine came back as 90 milligrams per deciliter. An ultrasound shows a medium-sized collection medial to the allograft and a ureterostent in the correct position. There's no hydronephrosis, abscess or stranding. Perfusion of the kidney is well preserved throughout. So which one is the best next step in management? Do you clamp the JP drain? Do you do an AB-CT? Do you drain the collection by interventional radiology? Do you remove the stent, or do you insert a Foley catheter? All right. I was expecting 100 after that slip on my side. All right. So this is a very, very important kind of diagnosis that you want to make, and this is urinary leak. So the creatinine on the JP drain should be very similar to your creatinine in the blood. So a creatinine of 90 milligrams per deciliter. So this is urine. This is concentrated creatinine. And you're suspecting a urinary leak. The first thing you want to do is insert a Foley catheter, because you want to decompress the bladder as much as possible. Decompressing the bladder frequently allows healing of the leak, so you don't require surgical interventions. The surgeons hate to go back and try to fix these things, in particular early after transplant. So put the Foley in. You're gonna watch for a couple of weeks, and then you decide about next approaches. All right, hepatitis C infection and transplantation. So we have a 42-year-old woman who has a history of IV drug use, hepatitis C, who had membranous proliferative GN as a cause of kidney disease. She's waitlisted for a kidney transfer the past year. Liver biopsy shows stage 2 fibrosis, and she failed interferon therapy. She asks if she should be treated for Hep C prior to her transplant. So what all are true except about HCV infection and transplantation. Hep C can be safely treated with interferon alpha and ribavirin post-transplant. Hep C is a risk factor for post-transplant liver failure and death from sepsis. Treating HCV prior to transplantation is highly recommended on this patient. HCV RNA titers are not useful in assessing the degree of liver damage, and kidney transplantation provides a significant survival advantage to HCV infected patients. So we had to choose the wrong one. Oops, let me press here. Go ahead, guys. You can vote now. All right, so it's kind of spread out here. But most of you, 38%, got the right answer, which, you cannot treat a transplant patient with interferon alpha. That triggers rejection. So what are the other things that are important? So now we have these new antiviral drugs. We've seen occasionally at lunchtime of actually a complication of that. But, the side effects are quite low. So the majority of our patients, should be treated for this prior to transplantation. There is a strategy, though, that is being done by some programs, which is not to treat this patient for Hep C and then select HCV positive donors as potentials on the deceased donor list. So this can shorter your waiting time significantly because you're getting a Hep C positive kidney. And then once you get the kidney, a few weeks later, you can get a treatment for that, okay? So some programs are using that to try to get patients that are low on the list up to the top. I think this may change as we are doing more of these protocols and even expanding, if you probably recently see on a New England Journal of Medicine paper where they're taking HCV positive donors and transplanting into HCV negative recipients and then treating them with antivirals after transplantation. So this is an area of transition. But I think, one of the issues sometimes with this interventions is that the medication is extremely expensive. So we don't want to, give a HCV positive donor kidney to HCV negative if we don't have, a complete, case of HCV or antiviral treatments approved, because otherwise you're putting the patients at risk. So doing HCV positive to positive, it's at least something that's acceptable, and the others, it really requires careful assessment and from the transplant program. We have treated over 26 patients with these agents post-transplantation. So these are patients that had Hep C, were transplanted, and then we gave these antiviral treatments afterwards. And the sustained virological response were extremely good. Okay, and here we separated into those that had stage 0-2 fibrosis or 3 and 4, and we see that 2 patients that failed this treatment were the ones that have more advanced fibrosis. But even though they failed the initial treatment, when we converted them to another combination of antivirals that were available, they were able to clear the virus. Okay, so at least the evidence that we have now from our study as well as other studies is that it is safe to treat these patients after transplantation in general. And there is a small risk of triggering the immune response and maybe triggering autoimmunity in some patients. But again, it's a minimal risk, close to the benefit of getting rid of the Hep C viruses. This is a plug for the Renal Fellow Network. So this is a blog that's mostly for fellows. Some faculty also kind of read it and encourage their students and fellows to follow. It is a blog that was initially created by Nathan Hellman, who was a co-fellow with mine that unfortunately kind of passed away very early. But it has become, now supported by the NKF, the ESN, and he has blogs about interesting cases, about interesting topics. And so if you never check it on, please go on. This is the older website. They have a new website now, and it is really a wonderful resource. And we also encourage a lot of the trainees to write on those blogs. So because it kind of forces you, number one, to summarize things very shortly. It may be a case that you've seen, maybe a new paper that you read, and it's a great way of getting like 5-minute reading and get like good knowledge. So check it out, Renal Fellow Network. So diarrhea 10 years after transplant, and I think this is our last case. So this is a 44-year-old woman who had lupus, hypertension, got a deceased donor back in 2002, and now, comes in with heartburn and diarrhea for the past 3 weeks. So she's someone that has been quite stable, almost 10 years after her transplant, now having complications. Sure, she has a watery, non-bloody diarrhea. It's worse when she takes PO fluids or solids. She has no fever or chills and no sick contacts or recent travel. Her immune suppression is just consistent of mycophenolate and tacrolimus. She's slightly hypotensive, but not tachycardic, afebrile. Abdomen is soft, non-tender with hyperactive bowel sounds. Creatinine was up 2.4 from 1.8 at baseline. So which of the following tests would you order for workup, except a stool norovirus for PCR and rotavirus antigen, a colonoscopy, adenovirus, PCR in the blood, Clostridium difficile toxin, and FK level? Great. So most of you got the right answer. So I think colonoscopy would not be our initial workup on this patient. I think, it's really important to think about norovirus and rotavirus. Actually, norovirus is the most common cause of chronic infection, diarrhea in the transplant population. For sure, diarrhea a lot of times can be medication related, in particular the mycophenolate. So that is also to take into account. But you're doing some tests here to exclude infectious causes. Adenovirus can also cause diarrhea. Adenovirus have different serotypes, can sometimes cause just urinary tract infections. Sometimes they affect the GI tract. Clostridium is also a good option. And definitely you want to get FK level. Remember, when you have diarrhea, opposite to what you may think, the absorption of tacrolimus is higher. So you have higher trough levels. So you want to make sure that you do that. Patients that have persistent diarrhea after the negative initial workup, maybe after switching some of these mycophenolate to other agents, then you may consider doing a colonoscopy and doing a biopsy. CMV can cause diarrhea, and sometimes you have a negative blood test for CMV, so you actually have to go after the tissue, biopsy the gut in order to be able to identify that. The second thing that's important about diarrhea is that it's associated with significant mortality after transplantation. So you got to keep an eye on these patients. In particular, ask them about bowel movements, and also it's something that really kind of affects these patients in the long run. So why does FK in diarrhea have this, opposite effect? And the reason is that, there's a lot of metabolism that happens in the mucosa of the gut. So this is driven by what we call a P-glycoprotein that transports the tacrolimus back to the lumen of the GI tract. So when you have inflammation in the intestine, suddenly you don't have that transport back to the intestinal tract. So you get greater absorption overall. And there's also some inhibition of the CYP3A4 activity on the enterocytes that can also be influenced on that. So this is just to show you a study that looked at tacrolimus levels in patients with diarrhea compared to controls. So it can significantly increase the trough levels. And this is a study just proving that diarrhea is associated with almost double the risk of graft failure as well as patient death. And I'll stop here and take any questions. Thank you.